Thank you for joining us. Please welcome your panel to the stage.
Well, we got St. Elmo's as an intro, so it's got to be good, right?
Totally.
It's going to be good. I'm Alice Park. I'm a senior health correspondent with Time, and it's my pleasure to be moderating this session in addressing global collaboration for eradicating women's cancers. And I have to say, I think the panel we have here today is really uniquely qualified to address that. They work in 4 different continents and represent a range of different health systems and also come from different sectors, public sector, private sector, and community and civic groups. So I think we're going to have a very lively discussion. Before we get started, I want to remind everyone that if you have any questions, feel free to enter them on your app, and I will go through them and probably incorporate them throughout the discussion rather than waiting at the end to do a Q&A. So feel free to do that throughout the session. And I thought we would kind of divide the next hour into discussing 3 components of this collaboration. And first, I think we'll tackle diagnosis and screening, and then talk about treatment, and then move on to research, just to kind of organize the big umbrella that we have to cover here. So I'm going to ask each of you to address really in where you come from and in the sector that you work in. What, in your view, is the biggest challenge or the biggest priority for you? And let's start with diagnosis and screening. And Usman, let's start with you and the work that you're doing in Nigeria.
Okay, so thank you very much. By introduction, my name is Usman Malemi Aliyu. I'm the Director General for the National Institute of Cancer Research and Treatment. My institute is a governmental agency under the Federal Ministry of Health that is purely carved out of the ministry, purely for cancer control. All the activities of the institute are geared toward cancer prevention, research, treatment, and control. It is an innovation that is made by the state, considering the amount of wealth that was spent on cancer control in the country before the establishment of the institute, but to no avail, with very little or none to show. So it was actually a governmental innovation, first of its kind in sub-Saharan Africa. So I'm happy to say it's actually a great feat by my government to establish that. And since the establishment of the National Institute for Cancer Research and Treatment, which we call NICRAT, a lot of activities had been unrolling. Currently, what we did was we started by developing policy documents, what we call the 5-year strategic plan for cancer control generally in the country. And we have laid down a lot of emphasis on improving prevention, cancer prevention and control. We all know the incidence of cancer in sub-Saharan Africa is increasing, just like any part of the world. But what is scaring is that part of the country, that part of the world is bedeviled with infectious disease-related malignancy, which are actually low in incidence in the Western world. So looking at the population and the continuous rising incidence of the cases of women's cancer, now the Institute developed a policy document, purely one for cervical cancer control. Cervical cancer is actually the second cancer in terms of morbidity and mortality. The first is breast cancer. The next is prostate, which is not a woman cancer, but purely for men. But it suffices to say that we have ovarian cancer, which is the fourth in the country. So, and the incidence is actually rising continuously. We have a lot of, discussion with renowned oncologists in the world. One to mention is Prof. Pekin, which conducted a research and indicated that the incidence is going to continue to rise globally. But in the next 2 decades, what we are seeing now, what was reported in 2022 by the Globacom, is like that incidence is going to double. And what is most scary to us in that area is that there are about 75% of the increase, according to his projection, is going to come from the low and middle income countries. And then my minister used to say that DG is like the country or the whole world, but to be specific, because I'm in Nigeria, it's like we are facing a war. That cancer is posing a great challenge in the country, and we have to be seen. We have to do something, and that was why the institute is currently established. So, in the area of cancer prevention, we've started doing a lot. Generally, in women cancer, what we are currently doing, or what we did, is actually to conduct an environmental analysis of actually what just part of the behavioral science, what are actually the behavior of women in terms of seeking health. So what we realized that there are a lot of barriers in that area, starting from the socio-economic, traditional cost, and so many others in the country. So one of the key strategies that was actually taken by the Institute is to increase awareness campaign in actually women cancers. And that has actually or greatly increased the awareness and the turnout of patients to actually come for screening services.
So more education about cancer.
So education,
and
yes.
risk
Yeah.
Yeah.
So I think with that, the Federal Ministry of Health, through my agency, now see that we have like a lot of people turning out to seek for these services. Well, then we've realized that while we're having more people, more women coming out to seek for these preventive services, the services were not available. So what did we do? So we actually partner with some institutions within the country, and we were able to divide the country into 6 geopolitical zones. And the key centers, oncology centers or cancer centers in the country, the hospital as a tertiary hospital, we were able to establish what we call a preventive oncology services. So we built a specific clinic where a woman can walk in and then seek education or information about cancers.
So
and
really building from scratch then.
Building from scratch.
System
Building purely from scratch.
to address the demand, which is good.
Yes,
the increase in demand is good.
Yeah.
But,
So generally what we have in the country, we have 6 centers, mainly in the tertiary centers that run this preventive oncology clinic. A woman can walk in and get the information regarding cancers. She can get herself screened. Usually we have a mammogram, mammography machine, we have ultrasound, colposcopy, and all that. And we have GPs and some oncology nurses, trained oncology nurses that are there that are always ready to attend to this cancer patient. Give them the required awareness. So that is what we have started. But in the long run, what we are working at, because the larger population of the women or populace in Nigeria are living in the rural and suburban region. They are about up to 80%. So there is no way, and most of the centers are located within the cities, so the urban areas. So currently, we are working with international organizations like Siemens Healthineers and one other organization to acquire screening vans, mobile screening vans. And we're going to, we've actually gone a long way in the procurement process of all these vans. And the intention is to send one screening van per region to go deep down into the community. And it's, each van is well equipped with an ultrasound machine, a mammography machine, colposcope, and then the HPV and testing kits. So that is currently what we are doing to improve the screening services, in addition to health education, awareness, and health promotion that we are giving.
Okay, that's quite a lot, and I definitely want to come back to explore some of the things that you've done, because it's really remarkable. Yeah. Danielle, I want to turn to you, and we have kind of a very different health system. You work with the Moonshot program, and here in the United States, of course, and very different health system, very different sort of stage at where we are, right, in terms of women's cancers, but maybe not so different in some ways from the challenges that Usman is working with in Nigeria.
We were able to speak last night, and I heard all the great work they've done in just 2 years, and there is a lot of similarity, even though the system is very different, because when you talked about opportunities or barriers in screening and diagnosis, I, like my colleague, would go even earlier and say, yes, when the President and First Lady reignited the Cancer Moonshot in this administration, they set goals to decrease the death rate from cancer by at least 50% over 25 years, and to improve the experience, improve the support that people and families get going through a cancer diagnosis. And when you set priorities in that large of a goal, you look at what has gotten us improvements in the past, and it's prevention and screening, right? There is incredible science being done, and the promise of new targeted treatments is already real for some and will be real for many others soon. But the reason that that marker that we're following, the cancer death rate, age-adjusted cancer death rate, has gone down is because of mostly due to huge gains on prevention and early detection. And so where I see the biggest opportunity, both here in the US and around the world, and we've been leading some of this most recently through a quad cancer moonshot, which brought together the leaders of India, Australia, Japan, and President Biden, is around HPV-driven cancers and eradicating cervical cancer, which is already a World Health Organization goal. Now, cervical cancer is not the biggest killer of women across the world, but imagine if we can wipe a cancer off the map, right? Like the idea of creating a cancer moonshot is to evoke that sense of hope and opportunity. And if we can use HPV vaccination, HPV screening, to really target who actually needs to be screened for cervical cancer, so we prevent it largely or wholly, and we detect it early when we can treat it, that just having that success under our belt will propel us forward to do so much more.
And could serve as a model, right, for how we start thinking about cancer, and not as sort of a monolith of something that, you know, you just sort of chip away at, but something that maybe you
or
really
that you
can
just
move the needle.
wait and hope it doesn't happen to you, right? Like this is where you can actually take the power back, and you can come out the other side with a totally different outcome.
Yeah.
Right. I want to turn now to the private sector. And Roberta, you work in China with a private healthcare company, United Family Healthcare, which I think some people might think, what role can a private enterprise have in a system like China's, where, you know, the state is involved? And I think a lot of us, maybe myself included naively, think that there's probably, it's a lot easier, you know, because it's state controlled to adopt and, you know, implement policies, especially around screening. What role do you see private enterprise playing in a system like China's?
Right, so yes, I am the founder of a private healthcare system, and we're lucky to be able to take care of the most privileged people in China who can afford private care. But we also have a foundation, and we get to work in the low resource rural areas as well. And one of our projects is trying to be part of this worldwide team to eradicate cervical cancer. And the Chinese government has been, in fact, investing in screening since 2005. But unfortunately, despite their efforts, the rates of cervical cancer and the mortality has continued to rise. So as against the 4,000 deaths we've had in the US in the last year, we had over 60,000 deaths from cervical cancer in China. And so we began to take a look at, what was it that was happening despite their doing all this screening. So what we found out is that in the low resource areas, they'll go and have a quota to screen a certain number of women, which they do. They give them pap smears. And getting these women to come in for the screening in the first place is a difficult thing. They come out of the field and they'll do the screening, and then they go back. Their sample goes to the provincial capital, and the results don't come out for a week, 2 weeks. And these women are back in the field and have forgotten all about this whole context. And usually not a lot of education or information goes along with it. They don't know why they were doing the test in the first place. And so getting them out of the field again to do any kind of follow-up is almost impossible. So many women are lost to treatment. And we've taken a model that we learned from, actually from some people in the United States that can deliver the results. So either we'll use a mobile PCR or mobile DNA lab, get the results within 3 hours. We'll screen, we do groups of 10 at a time, give them education about the reason they're there and what HPV means, and teach them how to self-sample, which post-COVID has become very, very easy because everybody knows about swabbing in their mouth, and you just tell them it's a different part of the body, but the same thing. And because of social practices in public laboratories, nobody's shy to drop their pants at the same time altogether, and it becomes a very sisterhood thing to do. And we say, don't go home for 3 hours. If you get a call, come right back, and we can follow up with cervicography and treatment from almost all of the disease that we can see. Then we take biopsy back, and we'll follow up if necessary if somebody needs further treatment. And so we've been doing this for like 6 or 7 years, going out several times a year to rural areas. And slowly but surely, the scientific community, the policymakers are starting to see that, well, maybe this is an approach. So we have a project that we're starting now that we want to stay in one rural province for 3 years and do screen 15,000 women a year and vaccinate the young women. And also do the same thing in an urban center of migrant population who aren't getting care as well. And having that 3-year period, hopefully showing some kind of drop in the mortality of cervical cancer. Also, at the same time, giving those women screening for breast cancer and showing that we can make a difference by doing that kind of proactive screening.
Okay. And David, I'm wondering if you can address from the diagnosis and screening perspective what AstraZeneca is doing as a global company, looking at kind of, as Usman was telling us, the rise in women's cancers in certain parts of the world, something we're familiar with in the developed world, but as we see these patterns emerge, what is AstraZeneca looking at as far as improving and finding ways to increase access and equity for screening?
Yeah. So our core focus, and Danielle, I appreciate you acknowledging it, is really focusing in on innovative medicines. The real clear picture, though, is that you cannot improve outcomes for patients across the globe if we're not detecting cancer early, we're not diagnosing it in a precise and timely fashion, navigating to treatment, and then ensuring that patients are able to stay on treatment as appropriate. So really within the last, I'd say, 5+ years, we've moved from always having commitment to companion diagnostics because that's the only way that really you could have a precise diagnosis that would result in a decision to treat with one of the medicines that we discover and develop, to having a much more expansive view about how we partner together in public-private partnerships in order to be able to have really more comprehensive cancer control plans. Yeah. And if you're able to, and I've found, and I think that through the moonshot conversation, or we're doing very interesting work with Macmillan in just launching today, actually, Ambition Zero within the UK, which is taking a look at how do we think from detection through to survivorship. How do we work together on closing those care gaps? So I think that's the most important place that we've worked within this. I think that if you take then one more step deeper in this, and I think the discussion on cervical cancer is great. Cervical cancer is an example of, through HPV and through the types of very straightforward approaches that Roberta describes, that we have today the innovations necessary to make immense progress in cervical cancer. So step one is, how do we just deliver today's innovations? And I think that whether it's in lung cancer or breast cancer or endometrial cancer, wherever you are, so that's one part of it. I think the second part is that I am also very excited about tomorrow's innovations. I think that the aspects of tomorrow's innovations that we're most excited about are, can we have less invasive ways of being able to, whether it's detection or diagnosis, and predominantly that's through blood versus tissue. So that's a much less invasive, in theory, should be much more cost-effective, can be delivered in a way that makes a lot more sense. And then also, in a lot of instances, the promise of AI is also something that, in the face of healthcare shortages, in an abundance sometimes of data, but not enough workers and trained workers to necessarily be able to go through all of it, how can AI help us to read scans, whether it's X-rays or PET or CT or whatever that might be? And so I'm also excited about how technology and innovation is rapidly advancing that allows us to actually further democratize screening and diagnosis. So instead of it creating a further technology or digital divide, I actually think technology offers the possibility to drive more equity in, as the way that you just asked about.
Okay, interesting. We're going to come back to the issue of equity, but Jem, I wanted to ask you, you work in the UK with a national healthcare system, obviously, and even with a system like that, what are some of the gaps? And we often see cancer diagnosis as being very life-changing, and I know that you work a lot with addressing sort of what comes after that. So wondering if you could address two things. First is sort of just the access to the screening to begin with, and what you're seeing in the UK, as well as once those results come in, what are you seeing that people are still in desperate need for, that they really aren't getting their needs met?
Great question, and so lovely to be part of this panel. And there's so many similar threads that run through these very different contexts. So, as you said, in the UK, there's the NHS, the National Healthcare System. It's a socialised healthcare system. To give you a sense of the scale of how many people use it in cancer, it's like 92% of people with cancer are being treated through the NHS. So the NHS budget is like 183 billion, and the private healthcare market in the UK is 11 billion, just to kind of give you a sense of the scale. We've got a Secretary of State for Health who says we need to drive greater improvements in the healthcare system in the UK. We definitely do. It does deliver pretty good value for investment in terms of outcomes for people with cancer and other conditions. And there's lots of opportunity in having a system like that, as you allude to. So we can roll out national screening programs or vaccination programs like we've done in HPV, for instance. But Macmillan, the organisation that I'm privileged to lead, is an organisation that focuses on care and individuals and people with cancer. And so when we're talking about diseases, I'll try and always bring it back to the women and the individual people who have those diseases and see them first, not the disease, because that's how we experience cancer, right? So Macmillan supported last year 2.3 million people in the UK with cancer. There were 3 million people in the UK with cancer, so we didn't get to everyone, but we will. But there's soon to be 4 million people in the UK with cancer. So the rate of cancer diagnosis is rising.
breast cancer, is rising. We're doing slightly better on mortality, but we're not keeping up with the rate that the incidence is rising. So there's a huge challenge for us in the UK about how is it that we can bring some of this excitement and new treatments and new technology, which undoubtedly are going to profoundly change how people experience with cancer. But how can we bring those equitably to people in the UK and around the world with cancer is a really big question. You'd think having a health system that's free at the point of use would mean that we weren't leaving anyone behind. That is absolutely not the case. And I've been interested in the conversations I've been in since I've been here, where there's a lot of obviously focus in the US about affordability, and affordability isn't a barrier in the UK. That does not mean that we do not have health inequity. We have very wide disparities in who it is who gets the best treatment, who gets diagnosed most quickly, who lives the longest, who gets access to clinical trials. Like, those inequities are real. And Macmillan is really focused on support for everyone, but starting with people who have the very worst experiences and starting in the most marginalised communities to work in partnership to understand how it is that we can genuinely eradicate cancer for everybody. And to do that, I think you have to start with the people who have the worst experience. But you asked me specifically about how some of those disparities show up in this space. So if we take the HPV vaccination programme that's rolled out across all schools in the UK, we still see that in the most deprived areas, you're twice as likely to not have consent from your parents to receive that vaccine. If we take cervical screening programme again, which is obviously across the UK, we see in some of the communities we work, so in the South Asian community, for instance, only 30% of women are up to date with their cervical screen. That is compared to other populations where it would be closer to 80%. So there are huge barriers still where it isn't affordability that is the challenge here in eradicating women's cancers. It's actually about understanding people and humans and women in this case, and all the things that mean that it can be difficult to show up for screening or to interact with a health system which isn't culturally appropriate and isn't giving you the support that you need. And some of those things I'm sure we'll talk about, but they're about caring responsibilities. They're about other things going on in your life that mean that it can be difficult to carve the time out for your own health. So I think we're going to talk about women's cancers, but let's all the time remember the women with the cancer, and each of those experiences is individual.
Right. And I think that's what we often hear, which is a common thread in every country, I think, is that women often shoulder the responsibility for the family. And I think you touched on that very eloquently just now, saying that often that means that they put themselves last. And that's why in many cases I've seen some experts even speculate that that's the reason why we see more advanced cancers in some cases, in some regions where, Usman, as you were saying, that women just aren't getting screened or just aren't thinking that they need that kind of care or should be getting that kind of screening. So I want to talk about treatment now, which is a slightly different challenge as far as access and equity. And we were just talking about the sort of fact that HPV and cervical cancer could be controlled significantly and dramatically if we were able to implement it and get it to people. So Usman, I want to start with you about how, with your institute, you're looking at that question and saying, now that you're sort of building this structure from the ground up, what lessons are you seeing, for example, from programs in the US, in the UK, in the developed world, that you feel are going to be useful in hopefully leading to higher uptake?
Okay, so in the area of cancer treatment, most especially the women cancers, as I've mentioned earlier with the prevention, the Institute is collaborating with some renowned institutions. I've earlier mentioned that Siemens, Healthineers. Currently, with the establishment of the Institute, we've just signed last week before coming the procurement of 6 new radiotherapy equipment for the country. We are a population of 200 million plus currently. but I think we only have there about 11 radiotherapy machines. And going by the International Atomic Energy recommendation of one machine by a million population, you can see that we'll be needing there about 200 plus. So access is still a problem in the country, but it actually suffices to say that we are starting with the 6 now, brand new equipment, to equip 6 more centers. Usually in the country, as I've earlier mentioned, we have 6 regions. So we are trying to provide like 2 machines, radiotherapy machines per region. And we think that will actually go a long way in closing the care gap in terms of access. Another very important factor that is actually pressing hard in the area of women cancer is the cost of this care. So that is actually a very big barrier because the NHS coverage in Nigeria is very poor. It is still there about 5 to 7% coverage generally. And the cancer is somewhat partially been taken care of. But currently, with the establishment of my institute, we've come up with a program that we called Cancer Health Fund. It is a kind of a catastrophic fund that is set aside purely for indigent cancer patients in the country that cannot afford that treatment. It's actually a line that is being put by, it's funded by the government of Nigeria, and then it's also open to philanthropists within the country to put certain amounts. So currently, we have a commitment from the Congress in the country to get like there about 20 to 50 million US dollars equivalent for 2025 to be added to that cancer health fund. And it's a kind of system, virtually the cancer patient that actually qualifies or satisfies virtually all the criteria that we put in place. After assessment by the MDT, primary physician MDT, can actually have an e-wallet which can be credited through a kind of a computer-based platform. An individual can self-register, he can be registered by his own physician. And through that, we'll be able to actually reach out to those indigents that cannot afford care and assist them with their treatment. Currently, we've treated like 200 cancer patients, including both male and female, both sexes. So I think that is actually going a long way in assisting the indigent cancer patient and assisting with the area of affordability and access. We are also into partnership with pharma companies through what we call a cancer access program, where we sign an MOU with companies like Roche, Johnson & Johnson, and some other companies like they agree to cut or they reduce the cost of their medication by 50 to 60%. And then through that, you can see reduction of 50 to 60% is actually a big one. And through that, we are able to increase and improve the affordability of cancer patients, mainly the women cancer patients, to be able to procure chemotherapeutics and even the targeted therapies in the country. These are just actually on pilot scale, but we are trying to see how we can expand it into more centers, because currently we are only covering like 6 centers of excellence within the country, but we hope to actually expand more. I would like to extend my hand to my colleague here, the AstraZeneca, if there's anything they can do. Actually, there is room. If there's any room for collaboration, so we are ready to partner and see how we can pull them into into the program. Yeah.
Okay, great. And you were all here when it started. David, I wanted to ask you about when it comes to treatments, we're hearing about a lot of innovative strategies. There's encouraging results from, a breast cancer vaccine approach. What, at this point, when you look at the field of women's cancers, we've got things like cervical cancer where it potentially could be dramatically reduced with an HPV vaccine, but what other cancers do you see that are kind of next in that low-hanging fruit category where, we have some either existing therapies or ones that are just on the horizon that really could dramatically reduce the incidence of some of these women's cancers?
Yeah, it's a good question. I think that, again, if we look at breast cancer, I think that there's an enormous amount of therapeutic options that we have available for so many women with breast cancer. And I think that as we get to it, there's challenges at postal code levels across the globe and making sure that we're able to deliver those innovations to the women who can benefit from them. I guess if I could, I actually think that, yes, the low-hanging fruit is important, but from our perspective, it's also really important that we don't get complacent about the individual women who yet don't have a treatment for them. So triple-negative breast cancer, something that continues to bother us as a company because it is simply defining a type of cancer on what it's not. You can't treat something that it's not. So if we think about who the patient is that is receiving that diagnosis, there is nothing comforting nor helpful in that diagnosis. And so I've been inspired by the women in the breast cancer community who encourage us to don't allow the progress that we've been made to let us in any way get complacent. Let's make sure that we're focusing in on populations like triple-negative breast cancer, which we need to have better definitions for, and continuing to work on what is driving their specific cancer. In ovarian cancer, we've made an enormous amount of progress for many women who we have a good understanding of what is genetically driving their cancer. Might be BRCA, or what could be as a result of their disease driving their cancer. There are half of women that we don't really have a good understanding for what that looks like. I think the other key piece is that for all of the advancements that we've made, way too many women are being treated with chemotherapy. And way too many men in lots of cancers are being treated with chemotherapy. So we're really working actively on how do we deliver more precise delivery of therapeutic approaches that they do kill the cancer cell, and that's important to have that as a therapeutic approach, but can we do that in a way that has different and better tolerability and toxicity profile?
Like paired with some of these exciting immunotherapies.
Yeah, or instead, and I think that, but to your point, and you hit on this other piece, so if there's ultimately two strategies when we think about targeting cancer, one is to directly target and kill the cancer cell, the other is to harness the immune system. And if we can do those together, and if we can do those early, and if we can do them early together and precisely tailored, that's really what we're trying to accomplish. So that's how we focus our efforts on treatment.
I would love to pick up on something that David said earlier, because I talked about how you prioritize once you have a goal like the President and First Lady set for us. And I agree. We don't have the tools, all the tools today that we need to prevent, detect, and treat cancer. So we have focused on innovation. We have protected and improved the budget at NCI, $4 billion over this administration as compared to the prior. A brand new agency in ARPA-H, created in a bipartisan way that we expect to be long-living, that doesn't supplant what NIH does, but gives you an additional approach to solve the problems that the investigator-driven research approach won't or hasn't solved. But the other way you do it is by making sure that more people have access to the tools you already have. And I think that's the healthcare access question side. A few of the things that we've thought about in that is the pipeline or the process of getting from screening to diagnosis to treatment, especially for low-income populations, rural populations, or populations with low access to the healthcare system. There are so many breaking points in that. And so we've started through a program through HRSA at the Department of Health and Human Services to pair federally qualified health centers, those that serve some of the poorest communities in this country, with NCI-designated cancer centers, so that as you get a positive screen and the outreach is great there, you actually have a pathway to get the treatment you need. The other thing I will mention that I think is going to change the game and actually is very similar to the work that you're talking about is reimbursing for the first time navigation services for someone with a cancer diagnosis. So this was something that went into effect a year ago, or almost a year ago. So through Medicare, through states that approve it, it's available through Medicaid, and private insurers and healthcare providers covering more than 250 million Americans have agreed to cover this and reimburse for this as well. So this is someone sitting with you, spending the time to educate you on what you're hearing from the care providers, on helping you access resources, whether that's travel or financial, helping you make decisions about your next steps, and accessing clinical trials and other things. And we think one that accomplishes part of our second goal of improving the support and improving the process of going through a cancer diagnosis, but it also improves outcomes. And for healthcare systems, in the end, saves them money. There's early data that we're seeing that the ER visits for people on treatment were actually cut to zero because they had someone to call.
Yeah.
They didn't have to show up at an ER with a symptom and say, is this a side effect or is this something going wrong? They had someone to call. So some of these solutions are simple, but they need to be, the reason reimbursement for this was so important, it makes it a part of the healthcare system. It's not an add-on that you can do if you have a good enough budget at a cancer center to provide it. It's available to everyone.
And like you said, that reimbursement is critical because so often we hear from physicians that kind of care, which patients are desperate for, isn't really incentivized in the US health system. So Gemma, I want to talk to you about the NHS and what challenges, if any, you face there for getting these types of services and care covered.
Yeah. Can I just say support the care navigation point though? So it's some work that we've been doing in the UK as well, which is just showing that in the most marginalised communities, having someone who is at your side, who you trust, who's from the community that you know, helping you navigate through is absolutely transformational. And it saves money. We don't invest in it because we want it to save money, but we understand that's the argument that we have to make in order for people to adopt it, because it improves
right, exactly.
care.
You have to show that in order for those services to be
then go nationwide.
Exactly.
Yeah, exactly. So we developed a model in Scotland, which is now funded by the Scottish Government. It's across all Scotland. I'm working hard in England and Wales. We are not there yet, but exactly on that principle. So the challenges, maybe I'll just give you a couple of kind of insights that sort of have driven some work at Macmillan that shows you how women who show up in the NHS get treated differently. Let me start with, men with prostate cancer, they turn up with a prostate cancer diagnosis and 98% of them report that the clinician discusses with them their sex life and erectile function and what's going to happen afterwards, 98%. All these cancers that we're talking about affect women's sex lives and how they see themselves and their confidence in that important part of their life. Do you know what percentage of women in the UK system report that a clinician talked to them during their cancer experience about their sex life? 11%. 98%, 11%. Why is that? And it's because we're treating women differently. So that has driven a lot of work that Macmillan's done around sex and cancer, aimed both at professionals and at people with cancer themselves. The second insight relates to some of the work that Dave was talking about around clinical trials, and particularly in breast cancer. So in the UK, black women with breast cancer are more likely to be diagnosed late are more likely to have a more aggressive type of breast cancer, are more likely to die earlier, are much less likely to be offered a clinical trial. And so we've been working, and this is where partnership is so important. We're a big charity, tiny in the scale of the problem we're trying to solve, but big. We work with community groups. We work with the pharmaceutical industry. We work with government, in this case, on this project that we've been doing, which is around access to trials. We work also with this organisation called the NHS Race Observatory, which produces another advantage of the NHS is you've got lots of data. We don't always make the most of it, but there is a lot of information in the system to really look at it about how you can build trust in communities that are underrepresented, because there are some very good reasons why they might not trust the health system, but also they're much less likely to be talked to by their clinician about a trial, because there's all sorts of prejudice going on that makes assumptions about whether or not people will be interested in a trial. So working at every single stage of the pathway to dramatically increase the number of women who are accessing trials from a group which is really underrepresented. And the result of that builds trust across the whole community in all of those areas that we're talking about. So this kind of community-based work, care navigation, understanding people who are having the worst experiences and partnering with them in the long term, for me, I've heard lots of people say there isn't a silver bullet. There is, that's it. And then you navigate to all of this other brilliant work. But you navigate it to people. You don't expect them to come to it and find it for themselves.
I also want to briefly ask you to tell us a little bit about the program with Boots, because I think it's also about meeting people where they are, right? It's to build that trust. You also have to sort of be there for people rather than having them come to potentially unfamiliar healthcare center, hospital, whatever it might be. So tell us about the program that you have with Boots.
Yes, so we've been partnering with Boots for, I think, about 15 years now, for a long time. And they're obviously
it's a fantastic pharmacy chain that you
They're
can
a pharmacy chain, but it's the same as Walgreens, which people here will know, same company. And so we have in every Boots, which is on every high street in the UK, a couple of roles. We have a Boomba, which I love the name of that, which is a Boots Macmillan beauty advisor. And what they are there to do really is to talk to women, predominantly women, not only women, but about any changes that they might be experiencing in how they look. So one of the other differences is like 60% of women going through cancer treatment say that they've got concerns about how they look. Men also have concerns, but only about 10% of those report it. So it's another difference. So, and that role's expanded now to talk about prevention and what sunscreen and about changes in your skin, about reactions to treatment, all sorts of things. So they're based in every Boots. Also, we have Boots Macmillan pharmacists who are there to talk to people about their treatment. Do they understand what's happening? And then they navigate back through Macmillan's community work to us or to other places where they need to. And the important thing, as you say, I think in that is about partnership. So what is it that big multinational organisations can do? They can do a lot, because we don't have a presence on every high street. And it's about kind of really this shared sense of being driven by what's the thing that we both want to achieve, like shared value, which is we want the experience of people with cancer in the UK to be better than it is right now, and what are the areas that we can collaborate on in it. And then just to tie it back particularly again to the topic, there's also loads of interesting work we're doing around data. So when you shop at Boots, you have an Advantage card, which is a store card, but it records lots of data about what it is that you're buying. And what we're working with them on is evidence around what is it that what you're buying can tell us about what cancers it is that you might have. So there's really interesting work happening on ovarian cancer, for instance, that bloating, it's really the reason we diagnose it late is because the symptoms come late, and often they're not recognised as cancer symptoms. But actually there's behaviours in the things that you are searching for and the things that you're buying that will tell us or alert us to the fact that you might be of higher risk. And then we can intervene and say, have you thought about this? Have you done, so we're developing at the moment a risk checker. So what's the trigger that might mean that someone might just want to go through a series of questions that might lead them to have a conversation with a healthcare professional? So I think it's just another example of where Macmillan could never do that. We wouldn't even be able to think about doing that on our own, but we can do that sort of work in partnership with others, and it can be really transformative.
Right, it's a great example of how we really need to think outside of the healthcare system in many cases, right, in order to achieve and move the needle on some of these things. I want to move on to research and start with a question from the audience, which is a lot of funding and research dollars and attention have been focused on the major cancers like breast cancer, endometrial cancer. Wondering if any of you would like to speak about what can be done about some of the understudied gynecological cancers.
Well, I'll start in saying that I think that one of the most important things is that we continue to create incentives across the globe for work to be done in rarer cancers. I think that one of the things that certainly here within the United States has been one of the best catalysts for work in this space has been the Orphan Drug Act. And I think that the progress that's been made as a result of the Orphan Drug Act has been remarkable. I mean, in fact, in ovarian cancer, we have a specific medicine for late-line advanced BRCA ovarian cancer that is really a direct result of an Orphan Drug Act creating a real incentive and a pathway for that to be something that can come and benefit women here. And I think that it is really important as we think about, whether it's here in the US or whether it's in Europe or whether it's in China, where there's just a tremendous amount of innovation that's taking place. I think that making sure that we are continuing to preserve those incentives is really important. And I think that that's something that I would like to see a part of all national cancer control plans and national cancer priority efforts, is to ensure that it's those rarer cancers that are continued to be put into focus.
I would love to add something I observed before coming into this role back into the White House 3 years ago. I ran a patient-driven nonprofit in ALS. And you want to talk about a rare disease community that is motivated to find an answer, it's people diagnosed with ALS. But what I saw continue when I came back into the cancer space is a shift in patients coming together to get information so that they can access great trials. And instead, they're coming together to drive research and create trials. And I think that's a really important movement that's going to benefit the rare disease community. They are coming together, they are fundraising, they're not just dumping it into a bucket that then gets dispersed and their thing isn't studied. They're working directly with researchers on the part of the problem that is meaningful to them and really driving impactful research. The other thing, because someone gets paid by the number of times we say AI these days, I don't know who, and David said it once, but I'll add a couple. I think one of the interesting things about AI is the challenge in rare is a data challenge. No one scientist or physician ever saw enough patients to really understand that disease. And so there's interesting work. ARPA-H funded someone who is looking at already approved drugs across the rare disease space and looking at basically every piece of information and patent and anything about what those drugs might target. And then matching that with all of the known understanding of a whole slew of rare diseases. And so that matching, being able to use AI and machine learning and drive new progress in understanding what we might already have in cancer and beyond that targets rare diseases, I think is a huge opportunity.
Yeah. Roberta.
Yeah, I heard the word incentives across the globe, and I heard the word data, and I just want to mention, I think, a really important concern that needs to be on our radar. Lots of great things have come out of collaborative research between the US and China and Europe and China, and slowly but surely there's wedges being put in between the scientific communities in Asia, or specifically in China and the United States. And with such rich data and such rich innovative community in China, I think we would be losing if that wedge continues to draw us apart. And the world would be gaining if we can continue to increase those collaborations.
I think that Roberta's point, if I could just on that, sure. I think it's a really excellent one. And I think that we have more power when we work together on research and development.
Here.
The delivery of medicine happens very locally. Right? So I think that's a place where you've got to work locally within community to be able to deliver a lot of what we do, but to find the solutions on the R&D side. And I think that I have found in my work that when I talk to most governments, most everybody can get behind the idea of eliminating cancer as a cause of
Who doesn't, right? Who doesn't want
or ending cancer as we know it, or eradicating cancer, or whatever the way is that we want to look at it. And so I think the more that we can create regulatory harmonization, clinical trial harmonization, minimize the number of barriers while preserving privacy, which is very important, and making sure that that's something that we get right. I think that we can address the privacy and security concerns while also harmonizing and facilitating better R&D work across the globe.
Yeah. And Roberta, David just mentioned clinical trials, and I wonder if you can address briefly the issue of what you're seeing when it comes to, particularly in the rural areas that you work in, how receptive people are to joining clinical trials or the idea of them.
I think there's a lot of enthusiasm where there's knowledge about that opportunity to join. But this is another problem. As our countries grow apart, people don't have access to clinical trials globally. And we're trying to facilitate that where it's needed through collaborations we have with Mayo and other health systems in the US and researchers in the US. But really concerned with this Biosecure Act looming. It's possible that it will be very, very difficult for us to be working together on clinical trials and for people all over the world to have access to the newest cutting-edge care.
In the few minutes that we have left, we've got policymakers, civic leaders, government leaders here in the audience today. And I'd like to ask each of you on the panel to address, if you'd like all of these guys to walk away with one thing, one priority that you feel should be addressed, that they should keep in their minds, as we think about this ultimate goal of eradicating women's cancers, what would that be? We'll just go down the line here.
Oh, well, I think I will start by saying that if we can eradicate or reduce the disparity in cancer care, cutting across the prevention, diagnosis, and research, that is what I will actually want our expert to look into. Currently looking at the clinical trials, the participation of the African Black Americans, or if I can say the blacks, in clinical trials is still less than 5%, and virtually a large chunk of the African community, let's say up to 40% are blacks. And there was a projection that was actually mentioned by Michael yesterday that in like few decades to come, Nigeria is going to compete with China in terms of population. So I think closing the disparity gap in the area of research and clinical trial is going to do a lot to improve cancer care in the country. And globally, really.
Yeah, Danielle?
Yeah, so the question I didn't get but expected was what happens to the cancer moonshot? And I'm gonna answer that because
Good.
It includes all of you. I think the reason that we've been able to get so much done is because the fight against cancer has been a bipartisan issue for decades. The President Biden, First Lady Biden started the cancer moonshot because cancer was personal to them, but it's personal to nearly every American. And so the work will continue. Federal agencies and departments have it built into their mission to accomplish many of the things that we're talking about across prevention, early detection, support and driving innovation that matters to people. But the real reason it's going to continue is because the Cancer Moonshot was never just a government effort. More than 200 companies, philanthropies, cancer providers, advocacy organizations, and others stepped up and made progress, took new action towards its goals. And so that is the work that I'm asking all of you to continue, because these goals matter to all of us.
David?
I think the top priority is that national cancer control plans remain a national priority for all countries across the globe. I think that the Cancer Moonshot put cancer as one of the national cancer priorities. The UK is now working on cancer as a national cancer priority and having a 10-year strategy. Nigeria has invited me in this meeting to participate.
Just minutes ago.
But it's really important. I think that policymakers have many, many people who come in through their doors asking for lots of different areas of help and interest and policies to be written, and it's important that we have cancer be a top priority within that.
Okay. Roberta?
Yeah, I'm encouraged to hear that we might not let politics get in the way of this very important goal.
What a concept, right?
Yes. Yeah, and that politics don't get in the, geopolitics don't get in the way of our working together, because there's so much for us to learn from each other.
Okay, Gemma.
I'm going to agree with what everyone else has said and just add that whatever it is you're thinking about doing in this space, start with the people that are least likely to benefit from it. So just ask yourself the question, who is most likely to miss out on this thing? And start with them. And let's not do what we've been doing for decades, which is design something which works for most people and spend loads of time trying to shoehorn that into the communities that need it the most. So that would be my one takeaway.
All right. Well, you've all got your marching orders now. So I want to thank all of the panelists for a wonderful discussion and appreciate the questions from the audience.
Thank you for joining this discussion. Please make your way to your next session, happening momentarily.
Very